I invite Dr. Prasad Matthews to moderate the session on equity in providing healthcare for the elderly in urban areas by Dr. Arvind Kasthuri.
Good evening to all. I'm happy to welcome Dr. Arvind Kasthuri, Professor of Community Health, to the stage. He'll be speaking on, equity in providing healthcare for the elderly in urban areas. Okay. Dr. Arvind Kasthuri is Professor of Community Health and Mentor Senior Citizens Health Service at the Department of Community Health. He's team leader of the St. John's Geriatric Center project, a unique 125-bed, 7-story facility on the St. John's campus, planned to deliver care, training, research, and community engagement services to elders and their caregivers. Dr. Kasthuri passed out, did his MD Com Health from CMC Vellore. And in the early 2000s, he developed an interest in healthcare of the elderly, resulting in the launch of the Senior Citizens Health Service at St. John's. He's been involved in practical community health activity as trainer, evaluator, and resource person to programs in different parts of India, including Bihar, Rajasthan, Madhya Pradesh, and Jharkhand. Dr. Arvind.
Yeah, thank you, Prasad. Good evening, I would say, ladies and gentlemen, and welcome to this brief session on providing healthcare to the elderly and the equity in that. Well, I generally, being from public health, I kind of begin with a slide like this, which generally shows what we are talking about, which is people and populations. And the more we learn about those people and those populations, I think the better. But today's focus for this talk is on one segment of that population, which is the elderly. And the topic of today's talk that I have been requested to throw some light on is equity in providing healthcare for the elderly in urban areas. But I must confess that I will probably be talking about providing healthcare to the elderly as a whole. You must give me that allowance. So just to say that we are in the decade of healthy aging, as declared by the World Health Organization, which is 2021 to 2030. We find ourselves at the beginning of that decade. Also, to draw your attention globally to the fact that the population of elders in the world is now you can see 3 lines there. There's the population 0 to 14 in red, and this population, and I don't have a here. Is that visible? Yeah, it is. So this is the line that I'm talking about, the world population of elders. And that population, after remaining somewhat static in the between 1950 to about 1990, has started to rise. And in fact, we are going to witness this unique phenomenon in about 2050, a demographic phenomenon where the population of elders is set to exceed the population aged 0 to 15 years, which is the first time in the history of mankind. So who are we talking about here? Now, I'm governed in making this talk by a couple of things that were shared to us by Anand, where he said, let's focus on the audience being also young postgraduate students to take away something from this. And the second thing is from our experiences in working in primary care. That's the perspective from where this talk comes. Let's start, like I say, with 5 things about the population of elders in India. First, obviously, the population of elders is large, but that's because the Indian population itself is large. Anything in India is large. I mean, millions roll off our tongue like single malt. So the population of elders in India is a huge population, almost expected to be in the region of about 149 million people aged 60 and above in this country. Now that's more than the combined populations of about 50 countries put together. And that's just the population of elders. Now, not only is that population large, but the proportion of elders in our population is actually growing. I mean, I remember making this point to a class of undergraduate students once in the afternoon in St. John's, and I said, the proportion is growing, and a guy caught my eye, and I said, why do you think that is? And I could see panic in his eyes. I mean, he's wondering whether elder people give birth to other elder people or whatever. So I hastened, of course, to reveal all, which is that life expectancy is rising, fertility is falling. These are graphs which show you this, which in fact in the morning, even Ritupriya showed us the life expectancy and what is happening to it in India. In the 1950s, our life expectancy at birth was a mere 35 years. But today, it is almost 70 years and is projected to rise as we go on. And not just that, the total fertility rate, which is the number of children a woman will have in her lifetime, has dropped from 6 in the 1950s to 2.05 now. So due to these demographic phenomena, the proportion of elders in our population is rising. And by 2050, we expect that that proportion is going to reach about 20%, which means that 1 in every 5 Indians will be a senior citizen. Now, that's a very sobering statistic, considering the size of the Indian population. Even today, we are talking about almost 1,400 million people. And a fifth of that being senior citizens means that there is a tremendous number out there. And we've got to think of all the issues that comes with that number. Okay, so moving on. Now, most of the elderly live in rural areas, just as the population is. Now, this is a figure from our 2011 census. We don't have a census after that, like we all know. But the figures now are somewhat similar. About 30% of our population now is urban. Even in the elders, if you think of that, of about 150 million elders, we are talking about almost 1/3, slightly less than 1/3 being urban residents. So it's as big a problem in urban areas, but the problem in rural areas is even, I mean, not the problem, the size of the population of elders in rural areas is really high. So another demographic phenomenon that we are seeing in the elderly population is this phenomenon of what is called feminization. Now, in this graph, there are 2 lines, and that shows the sex ratios in the general population and in the elderly population. Now, the general population still, unfortunately, continues to show an adverse sex ratio, which is the number of females per 1,000 males. But in the elderly population, we see a sex ratio which is actually 1,078. I mean, if you project that to 2031, 1,078 elderly females per 1,000 elderly males. And taking this further, if you look at a particular vulnerable group in that population of elders, it would probably be the single elderly woman. Now look at these 2 bullets here. Among older men, if you consider older men, 15% are currently single or widowers. But if you consider older women, almost half of them, which is 48%, are single. That's obviously because women marry men older than them, and as they move along, the guy falls off, and there's this lady who's there, right? And so this single elderly woman demographic is a particular area of vulnerability among the elderly population, which I think all of us should be very, very concerned about if we are talking about equitable distribution of healthcare in this segment of the population. So I've just put these as kind of takeaways, or I'm sorry, before that, the 5th point, of course, being this is a conference after all on healthcare. Now, when we look at the prevalence of acute chronic morbidity, musculoskeletal issues, and mental health issues, obviously, as expected, we know that the prevalence of chronic disease rises with age, and that is what we see. prevalence of chronic morbidity, any chronic condition, is almost 40 to 65% of elderly people. So not just the physical, mental, and social well-being interrupted with problems, but it leads to this phenomenon called dependency. And this is a graph showing you what we call the old age dependency ratio, which is simply the number of older people per 100 people aged 15 to 59. And the old age dependency ratio is also rising. So these are the 5 takeaways. I mean, we have a large population of elders. It is a growing population, mostly rural, but 30% almost is urban. And that's a huge number in absolute terms. The phenomenon of feminization and the particular vulnerability of the single elderly woman. And we know that the chronic disease prevalence in this group is high, as is dependency. So keeping in mind this, I just picked this diagram up. I, at this time, did not know that the logo of this conference is very similar to this, which is if we think of equity and actually making those who need it more, access to healthcare more to those who need it than being equally available to all, what are the challenges in delivering healthcare to elderly people? So I call them the 5 A's, just for us to be able to recollect what they are. First, of course, is the problem of access. Now, when you think of access in our country, we talk of different kinds of access. We talk of geographic access mostly. We say what proportion of our population has a healthcare facility within 5 kilometers of where they live. Now, but when you think of an elderly person, actually those determinants widen. It's not enough to have a healthcare facility close by, but you need somebody to go take you there. You need some way in which to go there. And perhaps you have other social determinants as well. So access or the lack of it, I think, is one of a very important issue when you talk about healthcare availability to older persons. Now, we thought that the National Program for the Healthcare of the Elderly would make access, or at least this barrier of access, less of a problem in the rural area, but we are still waiting. And I don't think we can continue to hold our breath on this program. More about this as I go on. The second A, in terms of challenges, is awareness or the phenomenon of health literacy. While we know that the absolute literacy levels in the older population illiteracy is high, health literacy, which is the ability of individuals and communities to understand information, services, make decisions regarding their own health. Now, if you look at that dimension, we know that that is also low among the elderly population. So the lack of awareness, obviously, is one of the reasons why somebody may neglect a health issue or neglect an older person, simply because they lack the health literacy to know that this is an early problem which needs to be tackled and can actually make a difference. These are just a couple of studies which talk about the association between health literacy and their healthcare access. The third, of course, now actually Ravi Dugal just covered this so beautifully in his presentation earlier, is the third A is affordability or the lack of it. Now, all these figures we've just seen actually in the previous presentation, where we talked about public health expenditure as a percentage of GDP. In fact, I thought it was 2.1, but I learned that it's 1.2 in the previous presentation. And more than 70% of all expenditure on health occurs in the private sector, which is again in line with what we just heard. And out-of-pocket expenditure is a big issue in this pie, which is when people expend out-of-pocket expenditure, what exactly do they expend them on? The biggest chunk of that pie is actually on medications and drugs and medications. And we all know again that those above the age of 65 expend more on their healthcare, required to expend more on their healthcare than the younger population. So again, since the elderly are particularly vulnerable because they have multiplicity of illnesses which are chronic and the chances of a catastrophic event is higher. This is also an issue which I think, if we are thinking of equitable access to elderly people, is something that we must be conscious of. The fourth A is what I call the absence phenomenon. Now, for those of us working in primary care, you know that you make a lot of effort to instill that awareness. And you say, okay, listen, you must do something about this problem. Don't just ignore it. Come on, take this older person and seek help. And when you go there, there isn't anybody at the health center. Now, all of us know that this phenomenon, I'm just calling it the absence phenomenon. This is according to our rural health statistics. Out of a total of so many sub-centers, almost 6,371 lacked a female health worker. And of course, I mean, I sometimes say that the male worker is rarer than the Indian tiger. At least you see the tiger occasionally on video clips and WhatsApp images, but a male health worker, I'm not really sure about. So, and of the requirement of so many doctors at a PHC, so many positions were vacant. So the absence phenomenon, or our human power crisis in healthcare, also affects equitable access for older persons as far as health is concerned. Now, this is just acknowledging who actually gives, I mean, which is the human power that we are depending upon when we talk about healthcare of older people. Families continue to be the primary caregivers. Health center staff, we need to depend on. If they are there, they are aware, they are trained, and they have the ability. And of course, we probably need to think of training people like geriatric nursing aides, geriatric physiotherapists, and of course, our administrators and doctors also need to be oriented to the care, to the needs of the older population. And the fifth A is again what I call accountability, or the accountability crisis that we have. In fact, Ravi Dugal also mentioned it. Now, what is the health worker accountable for? If you think of a healthcare worker in the system, what is that healthcare worker, or who is that healthcare worker accountable for? One, we believe that he should be accountable for professional competence, that is, solving the problem of the elderly person or the elderly client, legal and ethical conduct at all times, ensuring that whatever you do ultimately will benefit that population of people, adequacy of access, being accessible and available for your client when they require it, at all times promoting the health of that community and being concerned about the cost of what you're doing. So this is what the health worker should be accountable for in his or her dealings with his or her client, be it older people or anybody. And how do we make the right choices in our human power situation? Well, we need to hire the right people, perhaps, be clear in our description of what they have to do, monitor, supportive supervision, role modeling, and of course, punitive measures is the last thing we want to think about. But we really need to think about these 5 A's, or the challenges that our elderly population faces in terms of healthcare. The challenge of access, awareness, affordability, absence, and accountability. So in the setting of primary care, what if an elderly person actually comes, when I say to you, I really meant those younger healthcare providers who are going away with something from this conference to a primary care setting. What are some of the features or characteristics of older people when you deal with them? So one, we know that elderly people do not present early. Now, why is that? It could be because of a phenomenon we call ageism, which is, of course, you're 75 years old, you will have a pain in the knee. I mean, what do you expect, right? So it's normal. It's expected in an older person, right? Poor faith on the part of an elderly person saying, forget it, man. I don't think they can do anything for me, right? Poor access, we've already talked about, and of course, psychological states themselves. So the equity tip, therefore, for us, for a primary care provider, has to be something like this. We need to look for issues perhaps before they actually present when we are talking about older people. Second, they require more physician time and continuity of care. Now, it is not possible to cure most of the issues with which older people present. So therefore, we have to have set apart time. because they will have communication issues, their presentations are atypical, they need a little more comprehensive assessment than just putting recording a temperature, a pressure, and a respiratory rate and saying, okay, take a paracetamol. They probably require a little more assessment than that. Caregivers need to be involved, and continuity of care, because we are dealing with chronic illness, is very, very important. So again, what is the equity tip here? We need to set apart time for older people during and after our interactions with them. Third, elder people require more senior-friendly health facilities. I mean, how many of our health centers, in fact, even our larger hospitals, are designed for older people? I mean, with an older person in mind. This is a comment from somebody who visited a large hospital. What a hospital. Crowded OPDs, narrow corridors built for the fast and the furious, no toilet within a 5-kilometer radius, few seats, tired legs, long lines at the lab and the pharmacy. Now, this is a larger hospital, all right, but most of our health centers, are they elderly friendly or senior friendly, is a question that we need to ask ourselves if we are interested in being equitable in our distribution of healthcare. Fourth, they need a multidisciplinary approach, because after all, it's not just one problem that an older person has. It is a multidimensional issue most of the time. So we talk about horizontal cooperation with physiotherapist, nurse, social worker, and vertical cooperation with different lines, maybe different specialists of different kinds. And therefore, from an equity point of view, we need to understand that it requires a team to take care of an older person, ideally. And fifth, elderly people need a careful consideration of the cost of care. Anybody needs a careful consideration of the cost of care. But for an older person, it is particularly important because most diseases require lifelong treatment, require long terms of follow-up and continuity of care. So I'm not repeating some of these things because we've just heard them in the previous lecture. So again, this the takeaways from this, we must remember that older people do not present early. They require more time, more continuity. They need senior-friendly facilities. We need a multidisciplinary approach, and cost of care is a very important consideration. So what do we do, therefore? I mean, what is the way forward? Now, our government has got a whole lot of schemes and programs for older people. These are the different schemes and different ministries and agencies. The Social Justice and Empowerment Ministry actually supports NGOs to construct old age homes and institutions for elderly people. And just like that, all these agencies actually have something in their kitty for older people. But the LASI data, I mean, the longitudinal aging study in India data, shows us that the awareness of older people regarding these schemes is still pretty low. Now, this bottom figure here shows you that all India awareness of any concessions given by government in the country is about 28%, which means almost just a quarter of them actually know about these schemes. So I did mention the national program for the healthcare of the elderly earlier. I think that it's a nice program as it is conceived. But how much it is being delivered and how much is actually rolling out at primary care at the PHCs out there where it is needed, I'm not that sure. But in concept, this is what it promises to deliver. And I think that whatever little we can do to support a program like this, we should actually do. Okay, I'll end with just a mention of what we do at St. John's. This is our senior citizen health service. We started off about 20 years back now with the first, for us, the rural geriatric clinics in our rural health centers, and now expanded to a few villages, about 5 or 6, where every month a team goes and conducts a geriatric clinic at a primary care level at the village site. A home health service where a doctor and a nurse register elderly people living at home and visit them at home once a month just to see how they're doing, give them a pat on the back, check their medication list, try to nip in the bud anything that may be starting. Institutional support services where we visit about 4 old age homes run by Sisters for Destitute Elders. And recently we started something called the Grama Hiriyara Kendra, which is Kannada for Village Senior Center, which is modeled on the Anganwadi Kendra. In fact, Ravi Narayan of Sochara calls it the Elderwadi, which is a place where just like children come in the morning, stay during the day and go back in the afternoon, this is a center where older people come. We've trained somebody to go through a little physical activity and a little interaction with them. They spend time and go back in the afternoon at about 2:33. And we have now started constructing this dream project of ours to call the St. John's Geriatric Center a ray of hope. That's what it's called. We are hoping that this will be a kind of a boost to the whole idea of elder care where we are located. So that's it, ladies and gentlemen. I think before I finish here, I encountered this poem which I thought I'd share with you. My eyes are dimming, my hair is gray, my ears are ringing, can't hear what you say. My heart is weak, my lungs make noise, my knees, they creak, and it's soft, my voice. But my mind is at peace with me and with you. I'm having a lovely day, and so I hope are you. Now, the basis for this is a study on the mental health care of the rural elderly. It's quite some time back, no doubt. But they discovered that 19% of the people they surveyed said we are totally happy, elderly people. We are fine, we are having a lovely day. And I think our challenge is, can we increase that percentage? Can we actually, the definition of equity, which was presented to us in the plenary in the morning, was that everybody must realize the potential that they have. And for an older person, is it possible for us to increase that percentage and realize that potential? I leave you with that. Thank you.
Thank you very much, Arvind, for that excellent presentation. I think we have some questions from the audience. Do we? Yes.
One of the challenges that we found is, especially for elderly women, there is nobody to take them to the clinic.
Correct.
And this was a problem during COVID times that, they couldn't come to clinic because they're dependent on someone like son or husband who don't prioritize their health. So are there any models of home-based care or care near home for the elderly?
Yeah, well, the model that we are doing, which is the home health service, is a simple thing where we've got a small vehicle. We've got a team of a doctor and a nurse. And we register older people living in an area of about 3 to 5 kilometer radius around St. John's. And the doctor and nurse pay a home visit to them once a month. It's not in the nature of an emergency service. That is, the guy can't pick the phone up and say, listen, please send somebody immediately, I'm not feeling well. In which case we say, call 108, get an ambulance and come to St. John's emergency, because it's after all in a small radius. So this is more in the nature of a preventive visit kind of a thing, just to see that they're doing well and try to nip things early. But that's in an urban area. In a rural area, a home-based model, well, honestly, we've got our own rural health center where we've trained our own health workers. So between our rural geriatric clinics, which happen every 4 weeks, we've trained our health workers to pay a visit to the home of especially the older, the more frail, to see how they're doing, whether they're adherent to their medications, remind them about the next clinic and things like that. But I think we've got a long way to go in terms of home healthcare. And one of the things in the NPHCE, the National Program for Healthcare of the Elderly, is domiciliary care, which ideally is supposed to be delivered at the village itself, or by, again, one more thing we are burdening the ASHA and the sub-center workers with. But that is, yes, absolutely. We've got a way to go.
Thanks, Dr. Kasthuri. Excellent talk and summary of what the condition of the elderly is. this is more of a comment than a question, but I was thinking that there needs to be some sort of recommendation for elderly people also to get, public PDS essentially, the way there is for children and pregnant and nursing women. We know that the rates of malnutrition are very high for the elderly, and especially for elderly women, and especially for those who live alone. That also needs to be part of the package of services that are necessary for them, right?
Actually, we do have a scheme called Annapurna, where there is 10 kilograms of food grains given to indigent elderly people. It exists, the scheme exists. And but how much again? How much it is used, how much people know about it, and how much of a difference it makes in terms of nutritional status, we haven't really tracked. But that's arguably one of the very few, or perhaps the only effort at nutritional input to the elderly at this point in our in our governmental schemes. But yes, absolutely, we take your point. Somebody at the back, yes.
Thank you, sir. Mainly when we come to know as a physicians, when an elderly person being abused or violent at home, being as a physician, what steps we need to take, and is there any legalities which can support?
Well, elder abuse is, I didn't probably mention it, but yes, it is an issue. We know that, in fact, we have a day, I forget the date, but a day dedicated to the World Elder Abuse Day. There is, in fact, a day like that in the calendar, in the annual calendar. So elderly abuse is a problem, yes. And when you encounter it, what do? It is a very difficult area to actually intervene because of the obvious stigma associated with it in the mind of the elderly persons themselves. First of all, because they don't want to let down their family members in front of anybody else, and the resistance you face from the caregiver. So it's got to be approached by a mixture of counseling, reaching out to that person, talking, winning rapport, and trying to understand what exactly the nature of abuse is. Because the definition of elder abuse is very wide, from verbal abuse to neglect to isolation to actual physical abuse. So there's a lot of elements there. Legally, the only act that exists in that landscape as far as the elderly is concerned is the Maintenance and Welfare of Parents Act, which means that there is an act in place in India where children are legally mandated to take care of their elderly parents, and a parent can actually file a case against a child saying that he is not looking after me. So that's the legal thing that is there. But a short answer to your question, it's just a question of sensitivity, setting apart time, counseling, rapport building, and trying slowly to understand the problem, involving social worker, nurse, and caregiver in the discussion to try to solve it. But it is a difficult area. Yeah.
Thank you for a great presentation, sir. Considering our health system is becoming increasingly digitized, what role do you think digital health plays in elderly care in the coming time?
Yeah, well, we haven't done much on the area of digital health for the elderly. So I know that the area of in the urban area, there is a huge thing on wearables for older people and tracking their health parameters using wearables and trying to link them to some form of healthcare. But no, I don't know of any successful programs which have actually used digital platforms where older people can actually use a digital interface to record their healthcare programs. Maybe it's an interesting area of study. I'll leave it at that, unfortunately. Yes, Prasad, back to you.
Thank you very much, Arvind, for a thought-provoking talk and for the audience participation. So as Arvind said, it's an area that's going to increase in importance over the years. And I'm sure you have been sensitized to this area. And I think the challenge is delivering care to people where they are, as Doctor said. And large institutions should get out in front and do this, especially through the comm health programs and maybe the geriatric departments, which are starting up slowly in different colleges. Thank you.
I request Dr. Prasad to present the memento to Dr. Arvind.